Good morning, everyone, and welcome to this Monty Art. Today, I have the honor of introducing a good friend of mine, Giulio Russo. He's an esteemed colleague from Italy. He's currently working in Rome, in Policlinico Tor Vergata. He has a lot of experience and published really a lot of papers, especially in the mitral and tricuspid space. Today, we invited him to present his last paper, which is a very technical paper on how to understand all the movements in moving all the catheters involved in the mitral clip procedure. So, Giulio, can you start?
Thank you very much, Andrea. Thank you very much, Professor Latib. So, as Andrea told, we are going to discuss some movements with the knobs of mitral clip, and we are also going to see the small adjustments we can do when transseptal puncture is not in the correct position. So, this is the agenda. Transseptal puncture is the very first step and the key step of all mitral procedure, especially for mitral clip. Then we are going to see the basics of mitral clip knobology, and then all the small adjustment we can do when transseptal puncture is not in the desired and correct position. I used to be a tennis player, and my teacher taught me that positions and with regards to the tennis ball is more than half of the hitting the point, hitting the ball, the tennis ball. And I think that for the mitral clip procedure, the very key step is the correct position of transseptal puncture with regards to the mitral valve plane. Of course, if you are in the wrong position, you can still hit the ball and be successful, but it might be a little bit more difficult sometimes. There have been proposed several
Giulio, we don't see your slides. Are you sharing slides?
Yes, of course.
I can see them.
Yeah, I could see them.
Oh, God.
Yeah,
okay, then maybe it's my fault. Okay, sorry about that. I see that. Okay, sorry about that. Go ahead. Go ahead. Sorry.
And so there have been proposed several spots for the transseptal puncture, but most of them agree on the fact that transseptal puncture should be posterior in the fossa ovalis. Why we should be posterior? Because being posterior allows us to be high from the mitral valve plane. And we need to be high enough, first because, well, the device is somehow designed for precise distance between the mitral valve plane and the transseptal puncture, but also because we want some degree of freedom inside the left atrium. So moving to the TE images, if we see the bicaval view in the B panel, we should try to be inferior, and then when we move in the panel A on the short axis view, we should try to be away from the aorta so that we can be posterior. And usually before crossing with the needle, we take the measurement from the septum to the mitral valve plane in the 4-chamber view. Usually for mitral procedure, at least 3.5 centimeters are required to perform a good mitral procedure. Again, with the aim to be high from the mitral valve plane and also to gain some freedom inside the left atrium, we thought together with Francesco Maisano about having left femoral vein puncture. This is a matter of anatomy. I mean, we only demonstrated in a case report this concept, but we think that sometimes going left instead of going from right femoral vein can allow us to be more high from the mitral valve plane, and also to gain some freedom inside the left atrium. And I think that this might be particularly useful in case of small left atria. So, for example, in acute MR. But let's see some basics on mitral clip knobology. So the mitral clip device is made of, let's say, two parts: a guiding catheter on the left, and on the right you can see the clip delivery system. On the guiding catheter, there is a plus-minus knob. Instead, on the clip delivery system, there is an ML knob, and then here you can't see very well, also a PA knob, which is used more rarely. And here we can see the basic movements of the guiding catheter. As you can see, you can rotate clockwise and counterclockwise. If you rotate clockwise, you are going more posterior, whereas if you rotate counterclockwise, you are going more anterior. And here you can see both from above and also from the lateral view. If we use here we have the plus and minus movement. So if we do minus, like now, we are moving away from the mitral valve plane, and we are also going a little bit more lateral. Instead, if we rotate towards plus, we are getting closer to the mitral valve plane, and also we are moving a little bit more medial. Here you can see also from the lateral view, minus away from the mitral valve, plus we are getting closer to the mitral valve. And something very similar happens also with the M and L knob. Just a few seconds with the video. Yes, here again we have plus and minus movements combined with the rotation of the guiding catheter. So clockwise, we are going more posterior. Counterclockwise, we are going more anterior. And here we see also well, we already went through the M and L movement. Here there is a little summary of the video. So counterclockwise and clockwise movements, and the L movements keeps us away from the mitral valve and also a little bit more lateral. And if we rotate towards M, we are getting closer towards the mitral valve plane and also a little bit more medial. And again, plus movements in the A and C panel allow us to be more medial and also to get closer to the mitral valve. And instead, minus, we go more lateral and we go away from the mitral valve. Now let's see what happens if we don't puncture in the posterior side. And here we have too low puncture. So we are puncturing anterior and inferior. So the device is very close to the mitral valve plane. So the solution here is summarized in the 5 panel in the right part of the slide. So we need to give some minus and M, because minus keeps us away from the mitral valve plane, and then M allow us to bend the device towards the mitral leaflets. And here you can see both from the above and from the lateral view. Of course, this is something that is valid for this situation, but in general, for all the movements we do with a mitral clip. if we use, for example, plus and minus knobs, usually some small adjustments also with ML knob or with the rotation of the guiding catheter are required. So all primary movements somehow require some secondary adjustments, whatever we do in whichever situation we are.
So Giulio, can I ask you a question about this anterior inferior puncture?
Yeah, sure.
I understand the minus, it gives you height, okay? And because you do minus, you need more M, but also doesn't minus make you more of an aorta hugging trajectory? So what about your AP trajectory? How do you fix that if you do minus?
Yeah, so the AP knob is usually rarely used, but here it can be used. Usually it is used in combination with minus, and we can give some A.
Okay.
And also we will see in the opposite situation when we are too high, and then we will use the opposite, so the P with a plus, and so this might be a solution.
Okay.
It depends on how low we are or how high we are, but it's probably these are the only two situations in which AP knob can be used. Although with the latest generation of mitral clip, I think it's a less useful. I mean, it doesn't happen to me to use it very commonly, but it can be useful in these cases.
Okay.
And so here we have the too low puncture. Now, too anterior puncture. Here we are. Here we have what you were talking about, Azim, the aorta hugging. Here you can see from the model, probably it is either from panel A. We have the yellow dotted line, which highlights the aorta, the aorta root. And here you can see in the movie, in the video, that we are touching somehow the aorta root. So the solution here is to give some plus and then some ham. But in very often when we are very close to the aorta, we have also to combine some rotation of the guiding catheter, because we have to be somehow away from the aorta, so we need to be more posterior. And here you can see also in the video that the hands of this is Francesco Maisano playing with the mitral clip. He turns clockwise, and so he goes more posterior in order to be away from the aorta. So rotation of the guiding catheter, then plus and M knob allow us to do some adjustments here. Now we are in the opposite situation. So too high puncture, and we are in the posterior superior puncture, which sometimes it happens because usually operators want to be posterior, but they don't care too much about inferior or superior. So this might happen. And in this situation, as I was telling before, the combination of P and plus together with a clockwise rotation allow us to move away from the aorta and to gain some height, to get closer to the mitral valve. So clockwise rotation and then plus and P. I think this is the only situation in which AP knob can be very useful. And one final situation. Well, this is a posterior inferior puncture, and I think this is a landmark of Francesco Maisano. At least he always advises posterior inferior puncture not only for a safety matter, but also because it is easier to achieve, to reach the A3, P3 lesions, so the medial commissure. And here you can see, oh, sorry, the video doesn't go. Here you can see how, well, giving plus and M, which are this is the usual movement we use for approaching, the mitral valve, plus and M, you see how easier it is to reach the medial commissure, so A3, P3 lesions. But again, well, this is something on which there's not a common agreement. This is something I learned from Francesco Maisano, and I must say that it is useful in my common practice. What about being too posterior? Because everyone wants to be posterior, but is posterior puncture always safe? Of course, we don't run the risk to puncture the aorta, but sometimes it may happen that we have this situation. This patient had just undergone a mitral procedure, and after 1-2 hours, he started to be a little bit hypotensive. We checked on the echo, transthoracic echo, and he started to have some pericardial effusion, 20 millimeters more or less. And then we performed the TE, and we noticed this. He had some retroatrial hematoma, because what may happen if we go too posterior is that the catheter goes outside the right atrium and then enters again the left atrium. So you cannot recognize this kind of complication until you remove everything. You remove the guiding catheter of the mitral clip, and then it starts very slowly to have some pericardial effusion. So this is a very rare complication, and in this case, it was solved with a closure of the atrial defect. But it is important to know that this may happen. It's very rare. And at least for me, as an interventional cardiologist, it was not, it's something not to take for granted, because I'm not a surgeon, and so I know the heart anatomy, but I didn't know that there could be this space between the right and the left atrium. So it was, let's say, a useful complication for me to learn, and so I think it's very important to know. This is a very short summary. When we are too anterior, we run the risk of aorta hugging. When we are too high or too low, the trouble can be to reach the mitral valve and to grasp properly the mitral leaflet. And when we are too posterior, as I just showed, there is the risk of perforation and pericardial effusion. So in conclusion, transseptal puncture is the key for success of mitral procedure, and posterior and possibly inferior puncture is the ideal spot for transseptal puncture. Usually it is quite easy if we have echo and fluoro guidance, but especially echo guidance is useful in these cases. And of course, mitral clip knobs allow us to achieve procedural success even in case of wrong transseptal puncture. Thank you.
Thanks, Giulio. It was really a great talk. I have some questions for you, and then we will see if all the rest of the audience, they have other questions to ask you. First of all, I was reading your paper, and I was interested in, other than all what you showed us here, also some other techniques, especially you were talking about using the overstraddle in some specific scenarios. Where and when this can be useful, and which is the cons of using the overstraddle?
To be true, I very rarely need to overstraddle. So it is useful when you need to reach the mitral leaflet, and you cannot do with knobs. And but again, usually a good transeptal puncture, and also in the most dilated LA with this knobs movement, knobs adjustment, allow us to reach properly and to grasp properly the mitral leaflet. So overstraddling is something very, very uncommon. Also, when I saw other operators doing the mitral clip procedure.
Yes, I agree. Even in our practice, we rarely, if never use probably the overstraddling. I have a very good question here from Saul Rios, who is one of the interventional fellows here in Monty. He's asking you if eyes become the standard of care for guiding transseptal puncture in the near future. What's your opinion on the use of eyes for the eye?
Is there an Edwino in the audience to answer this question? No, well, just because when it was in London, Val, I attended the session on eyes by Edwino. It was very interesting. I think that eyes can play an important role both for mitral and tricuspid intervention. It happens sometimes when I was, especially when I was in Zurich, but also here in Rome, that the window, the TE window, was insufficient, and so we required the eyes. Well, you know, standard of care also means that you need to consider some costs. I don't know there in US, but in Italy, it is a matter you have to consider. ICE has some costs, and using it routinely means that you should add some other expenses for the healthcare system, which are not everywhere and not always wanted from from the hospitals. And so
maybe
standard of care.
Add our experience, Giulio, because we have a lot of access to 3D ICE. But in Europe, just for Saul, for you to know, there's only one 3D ICE catheter, which is the Siemens catheter, which is probably the worst out of the 3 catheters that are available. The Philips and the Biosense Webster catheter are much better. For mitral interventions, we've done a few mitral interventions now, ICE only, because the patient couldn't be intubated or we couldn't pass a TE probe. It's feasible. It's challenging though. I think TE is still going to be the standard for mitral procedures, and maybe ICE for more challenging cases or for cases where maybe you can't intubate a patient. But I think TE will be the standard. It may be a little different on tricuspid, but I think Giulio mentions an important limitation, which is costs. And the price of these catheters are, close to $4,000 here in the US. So it chews up a lot of the costs of, of the procedure.
Yeah.
Go ahead, Andrea.
Great. Maybe we can ask Antonella. I see she has a question. Antonella, she's a research fellow with us.
Hi, good morning. But first of all, Giulio, thank you very much. I think that the simulator, the video that you showed are really helpful because, in our training program, we go straight to the cath. So the anatomy is something that you can imagine, but then I think I'm being in the OR just a couple of times. So yeah, thanks. It's really helpful. I have a couple of questions for you. First, the basic one. What do you think are the main complications during the procedure? I think, it's pretty safe, but have you experienced some bad complications? Then the second one is how do you manage in your center the SAD that you leave behind? Do you usually close it? What is your opinion of the SAD that you have created, basically?
Okay, so thank you for the question. As regards the simulator, I just want to mention a quotation I heard from Gabor Thought from the PCR. I think that simulators are the missing step between the slides and the patient. So that it is not the first time when you have a patient in your hands, it is not the first time you are playing with the device. So
yeah, I think for training is the best, because at least you can see, and then yeah.
I think that everyone who can somehow do some training on simulators is very important, and it should be somehow suggested or guaranteed to all trainees. As regards complication, the one I showed on posterior transeptal puncture was the most difficult to diagnose for me, because as I told her, I didn't know this kind of complication, because I didn't know this peculiar feature of atrial anatomy. Well, then it may happen everything. I mean, starting from transeptal puncture, I think the most dreadful complication might be aorta puncture, but I think that with the TE guide, it should not happen. But you know, it depends on also on the expertise and on the quality of the images. And well, apart from that, probably mitral clip detachment, but also this is very uncommon to be true. So I would say it is a very safe procedure, and I think that this is the strong point of mitral clip procedure as compared also to mitral replacement. Mitral clip procedure is very, very safe, very effective. And as regards ASD, we usually never close it unless there's a bidirectional residual flow between the atria, but usually it's very uncommon. It happens a little bit more frequently with mitral replacement, but again, no. First choice is not to close. I mean, I don't know your experience in Montefiore, Azim.
Yeah, I think those are exactly the same. I mean, I think if I think about complications in the procedure, Giulio, I think we've seen like maybe an acute SLDA once that we had to immediately go put another clip. But I mean, I remember one case. I think pericardial effusion is probably the most common, right? That I think of over the years that I've seen. I've seen it particularly when we're training new people and they in the right atrium and they move around a lot. When they try to go posterior and the whole catheter jumps and hits the atrial wall, you could easily cause a pericardial effusion. And I'm glad you showed that picture, because I think that picture you showed, and maybe we can show it again, Julia, if you don't mind, because it's a really good learning picture. Yeah. So I don't know if you guys see this picture. This picture is really important because, you know, we often try to go more and more and more posterior. And the problem is there's a point where this case is exaggerated here, but there's a point where you go posterior and it's thin, and it starts thickening very slightly, the atrial septum. And at that point it starts thickening is where you actually, it's what's called Sondergaard's groove. It's this groove between the left and the right atrium, and there's just fat there. There's no actual wall there. So what happens when you puncture there is you go from right atrium through the fat into the left atrium, okay? But that little piece doesn't bleed when you first cross. But when you put your big sheath in and you make the hole now bigger, your 25 French, you know, transeptal sheath, then you actually, part of the sheath is sitting outside, has gone through and is sitting outside the heart. And like Giulio says, you don't notice anything until you finish the procedure, and then you pull everything back, and now you can bleed. And you know, in your case, you guys were lucky; you were able to close with the ASD device. Many of those cases have finished with stenotomy and open surgery to try and stop the bleeding. So I thank you for showing this, Julia. I think it's for people starting to do transeptal procedures. This is one of the most important lessons to learn.
Yes, and as we are talking about, some little tip, let me tell you also that from this procedure on, as we usually put a pigtail in the left atrium, in order to have continuous direct LA pressure monitoring, we decided to, when we end the procedure, to remove the guiding catheter, but to leave for 5 minutes the pigtail across in the LA, so
Nice.
across the septum, just to monitoring if there's some pericardial effusion, and then after 5 minutes we remove everything. This is something I don't know if you also, because now the Gen 4 allow us to have LA monitoring from the guiding catheter, but well, from the delivery system, but I'm still used to put a pigtail also for this reason, not only for the LA monitoring, but also for this, because somehow you feel more safe to be still across the septum, and to see if any complication occurs in the minutes after the procedure.
Sure. Go ahead, Andrea. I'm not sure who had a question. I see Manav and
yes, I'm here with
Andrea.
Manav. I'm here with Manav. I'm gonna say.
Oh.
Thank you, Giulio. That was great. I agree with all of the prior comments about how useful it is to actually see the model and see the importance of getting a good transeptal puncture on the your first attempt. I have a couple of questions. One is, do you use fusion imaging at all to co-register fluoroscopy and TE? Do you think there's any value in that? Is it maybe just something newer operators should use to help them kind of understand the relationship of fluoro to TE, or is it something that, in your opinion, should be used regularly? And my other option is kind of, what's your threshold to abandon a transseptal and make another transseptal, another hole in the patient's septum? Do you try to work through a suboptimal transseptal, or do you just try to get the best, let's say in this case, MitraClip result, and go for another puncture?
Thank you for the question. As regards the fusion imaging, I'm a little bit biased from Francesco Maicano, because it used to be that fusion imaging is just confusion imaging, and so sometimes it helps and is very beautiful to see, but I must say that well, usually TE is very clear, and we don't need too much fusion imaging, even if it is very beautiful to see also in the scientific publication, very good images in the congresses to show. To be true, if you ask me, it is a promising technology. I must say, well, I'm a little bit skeptical, to be true. As regards the threshold to abandon a transseptal puncture, I usually try to go anywhere. I try to also to push a little bit myself. I'm quite young, and I have not the experience of Azim or of Francesco Maisano, all big operators. So when I have some troubles with transseptal puncture, sometimes I try to change also the venous access site. So I try to go on the left to gain height, to see if the contact with the septum changes. And if I manage to go on the other side, then I will work on the knobs. And so usually, in my experience, it never happens that I had to abandon a procedure because of transseptal puncture, unsuccessful transseptal puncture. But probably it may happen one day, I don't know.
I think I remember us redoing a transseptal puncture once or twice, Manav, in the years we've done it. And I think the one where I remember was this patient with atrial functional MR, with a massive atrium, okay, that was just so huge, and we were just too high. As we were trying to, despite all these maneuvers, trying to reach the valve, it was just too far away. And the problem with mitral clip and Pascal is if you push the device very far away from where your transeptal guide is, it starts almost doing like a banana shape. It doesn't go straight anymore. And so you have no control over the device. And we tried for an hour, and then we just said, no, it's such a big atrial septum. We went like 3 centimeters lower, and we were still okay. And that was just by going from posterior. We went to mid septum on the AP, and we were fine. So I think occasionally it will happen in unusual anatomy cases, not in the standard case. I think Julio is right. In the standard case, if you go posterior inferior or posterior mid, you're going to be fine, and you can overcome it with all the tricks that Julio showed us today with the knobs.
Julia, maybe I have a question for you. I remember a case since when I was a student in San Raffaele, and sometimes the angle between the septum and the the mitral valve plane is not always 90 degrees. Sometimes we have a very dilated left atrium, and so this angle might be much larger. So this might complicate also our maneuvering in the left atrium. How do you think this will impact on our transeptal puncture and the maneuvering? I remember that specific case, the mitral valve was abandoned because it wasn't, let's say the distance was not enough to reach the mitral valve. What do you think about this?
Well, I think that it may happen. I'm lucky that it never happened to me. I think that probably in this case, being not only posterior but also inferior might help. But probably sometimes, as Azim told, trying to repuncture once you start to do some attempts with the movements inside the left atrium, and you understand what is the problem, probably you are too far from the mitral valve, you can try to repuncture, but well, it may happen sometimes. I think it's it occurs very rarely. I mean, when I have to think about mitral clip as compared to mitral replacement, I always think that mitral clip is very strong procedure because it's effective and easy, and it is, let's say, quite easy. Now it is widespread across the world, and usually, the procedural success is quite high. Instead, mitral replacement still, a lot of screening failure, a lot of technical limitations, LVOT obstructions. And so I always think that mitral clip set the bar very high for all the competitors, in this case, for mitral replacement. And so generally speaking, mitral clip is feasible, and especially in expert hands, and you can still achieve good results. Of course, you can find some complicated anatomy, complex cases, and probably results cannot be optimal, but you can still correct some degree of MR. And of course, sometimes you can fail, and you can probably reconsider for replacement or for surgery.
Thanks, Julia. I have another question coming from the audience. It seems that you impressed everyone with this complication. The question is always on this. So you say that you leave the pictal, the wire, across the transeptal puncture. Then you monitor for any pericardial effusion. Let's say you see a small pericardial effusion that is forming after 5 minutes. So what's your management? Do you give protamine and you wait a little longer, or what do you do in that case?
I consider to close the ASD. I mean, my experience is limited to the case I showed you. Well, luckily to be true. And but in this case, I don't remember whether protamine was administered or not. But you know, this pericardial effusion, I remember very well that occurred in 2 hours, because in the end, right and left atrium are low pressure chambers. And as Azim told, we were lucky to be able to go across the and to put an ASD closure device. So if I have this kind of complication, probably I would continue monitoring, and I would consider to close the communication between the two atria. I have only this experience, and in this case was resolved in this way. So I will do the same again. I don't want to run the risk to have a pericardial effusion. Also, because in this case, of course, we close the ASD, but first of all, pericardial drainage. So if I can avoid something more complicated, I do this. I mean, of course, it is one more device for the patient, but in the end, it's not a big problem for the patient.
Thanks. So very low threshold for closing the transeptal puncture. And I didn't give credit for this question, was from Chris Jenkins, one of the great interventional fellows we have here at Monti. So I see we have an hand raised, Andrea Mignatti, who is one of the interventional attendings here at Monti. Go ahead, Andrea.
Yes, hi, good morning. Thank you for this great talk, very, very technical. Mine is a generic question. It's like a more of a philosophical question for you. Is like, where do you see us doing, how do you see us doing these procedures in 10 years? Like, are there going to be more or less knobs? Like, ideally, I think it would be better to have less, right? Having one device, one single joystick, being able to move around like surgeons. Do you see this happening? What do you think is going to be the future?
Well, thanks for the question.
I know it's a philosophical question.
No, well, it's the right question, and I think it is always very debated. I think that there was also a review on the future of repair as compared to replacement. It's very debated, and I think that every one of us are somehow biased because of the background or the centers where we work. So somehow some of us can say probably repair is better, or we'll have more space than replacement. Some others replacement solves the MR, so it will be easier for in the future to do replacement for all. I think that there's not an answer for this question. I think that for the moment it is useful to try to master or to learn and to perform all this kind of procedure. And for the moment, I think that the therapy should be probably not only for the moment, but also for the future, the therapy should be tailored to the patients according to clinical and anatomical characteristics. I'm not sure that replacement, the one-fit-all myth is not going to work in this area, in my opinion. But in the future, we will see. For the moment, I'm quite young, and I'm trying to learn and to practice everything, because my concern is to try to provide to the patients all the options that can be the best for him.
Great. Thank you, Giulio. I think you addressed every question that was asked here from the audience, from the panelists. You gave a fantastic talk. We expect you from doing the same for the Pascal, and maybe come back on Montiart and show us the similarities and differences between the two systems. And thank you from all of us for giving this lecture in our Montiart conference.
Thank you very much, Andrea, and thank you very much, Azim. As I told Andrea when I was in Paris, I was and I am one of your followers on in these Monte Heart conferences since the very beginning. So it was a great pleasure and honor for me to join this conference as a speaker. Thank you very much.
Well, keep up the hard work and keep publishing. Okay.
Okay. Sure.
Okay. Ciao, Giulia.
Bye.
Good luck.
Bye bye.
Ciao.
Ciao,
Bye
ciao.
bye.